Let's hope so. Fabulous. Okay. So what I'd like to talk to you about today is the built environment. And the built environment is something that from a public health standpoint, I think a lot about, but from a medical standpoint, you might not be thinking a whole lot about it. So in terms of population health and public health, it's quite important to think about. So the first thing we're obviously going to do is define what the built environment is. So the built environment is anything human made in our surroundings. That can include things like buildings and neighborhoods and cities, but it can also include things like parks and green spaces. And the built environment kind of started in the pre-industrial revolution. So once our ancestors decided to, rather than wander around and killing animals as needed, and they started to settle down into communities and started permanent settlements, we started to alter the land. And at that point, it was just things like fencing off areas for crops or fencing off areas to keep animals contained, or putting a little path between the two. And then as those cities and villages began to grow bigger and people started living in them more and more, what the built environment did was that its job was to ensure basic needs were met. So we had buildings, houses, huts. We had pathways from point A to point B. There were farmland versus land put aside for animal domestication. And then as we get closer and closer to the Common Era, we see smaller cities and villages grow into larger ones. We see things like trade and culture and education and economics become important to people. We have more and more people, and the built environment moved from just thinking about basic needs to more comfort and desires for these people that are living in these areas. So that's all the pre-industrial revolution. The Industrial Revolution happened, and that's kind of when we started seeing problems occur with the built environment. So what we saw was we had a mass movement of people from the more rural areas, the more farming areas, into the cities and the towns. And unfortunately, the cities and towns did not have enough housing to supply these people with safe, appropriate areas to sleep. So we had the rise of tenement slums. We had lots of new workers. People were living in cellars. People were living on dirt floors. There was very little ventilation, very little sanitation, a whole lot of people trying to live in one room. There was a lack of clean water. There were gutters with sewage. Part of the reason for the Black Plague, because we were living in areas where the sanitation was awful and it was very easy to pass communicable diseases back and forth. And we also saw issues with safety. So not only in the areas where people were living, but in the areas where people were working, there were very few safety regulations. There was lots of machinery. There was lots of child labor and child deaths due to working in those machinery infested areas. There were, we had lots of mines trying to make the coal or trying to get the coal, and had lots of issues with that. So as the Industrial Revolution continued, we saw the people moving into the cities started having more and more issues with their health, that the built environment was, rather than it was making life better, it was making life worse. So around about the Industrial Revolution time, we started to see changes, or people looking at public health and seeing if changing those public health conditions could change the health conditions of the people that were living there. So the first person I love talking about is Jon Snow. This is not the same Jon Snow from Game of Thrones. Jon Snow was an epidemiologist living in London, and during the London cholera epidemic, he kind of figured out what was going on. So at the time, Vibrio cholerae was not isolated yet, and cholera was still thought as being due to miasma. And so what Jon Snow did was he made a map, an epidemiological statistical map of where people were living and the deaths in those houses or the morbidities in those houses. And he made this big old map of London, and he was able to see, based on that map, that the closer people lived to something called the Broad Street Pump, the more likely there was going to be morbidity or mortality in that house. So he went to the city planners in London. He said, look, I think I found a reason for this. Can we do something about this? And the city planners were like, I don't know, miasma, it's a thing. And Jon Snow's like, look, just take the pump handle off. If it works, great. We'll have a reason and the numbers will go down. If it doesn't work, then I'll take myself off. And so the city planners were like, yeah, okay, that's an easy way to shut this guy up. They took the pump handle off and they found that indeed the numbers of people contracting cholera went down in that area. They saw a decrease in the number of people with cholera. So what Jon Snow did was he, provided statistical evidence that the built environment could have an effect on health. The next person I want to talk about is Florence Nightingale. So Florence Nightingale was a nurse. She worked in the Army Field Hospital. And what she did was she created these graphs of the seasonal sources of patient mortality in the field hospital, so of the patients she was seeing. We still use these types of diagrams today, but in this case, the ones that you can see on your screen, the blue wedges are deaths due to preventable zoonotic disease. The red wedges are due to deaths from wounds, and the black wedges are due to deaths from all other causes. So not only was she documenting the conditions of medical care in the Crimean War when she was there, but she was finding a correlation between high death rates and bad drainage, or high death rates and contaminated water, or high death rates and overcrowding or ventilation. So Florence Nightingale is known as a pioneer of sanitary reform. So what we're doing is we're putting statistics to the environment and how that environment is affecting the health of people. And we're starting to provide, correlation, not necessarily causative proof, but correlation that the two things are in fact connected. Now, what we can look back on is the amounts of air pollution and what that had to do with health. Now, at the time, they obviously weren't measuring their air pollution in micrograms per meter cubed, but we can extrapolate based on the number of coal plants how the health of the communities were doing. So the more coal plants in one area, we can assume that that meant there was more pollution. And so therefore we can look at maps made now of air pollution in London or air pollution in Delhi and see, if that matches up with mortality rates from the area that we might have. So in the Industrial Revolution, we do know that there was a lot of stuff going on in the built environment that affected health. One of the things that the Industrial Revolution also did was it paved the way, pun somewhat intended, for transportation. So during the Industrial Revolution, life was a very pedestrian life. You lived a mile from where you worked. But as cars became accessible, as freeways became a thing, the cities expanded. And you didn't have to live a mile close to your office. You could live fair distance away and drive to work. So now we have commuters, and now we have to provide roads for those commuters. We need to provide a way for goods and people to get from point A to point B. So trains are a thing that we now have to worry about from a built environment perspective. Now we know that the built environment is not just buildings and pathways and houses and grazing land and farming land. It's also things like mass transit or civic centers or sanitation projects or public spaces and urban reform. The deconcentration of populations from the cities out into the suburbs is something that affects the built environment, which therefore affects health. We have separate residential and business areas. We have suburbs and the suburban spread. There is a need for an automobile. We can't walk from the suburbs to the cities. There is a need for some kind of transportation. Maybe you don't have an automobile, but you might be able to take a train. All of those transportation options provide air pollution. They lead to a more sedentary lifestyle, which are risk factors for obesity and chronic disease. So we started with farmland, we moved to the cities, and now we're moving back out of the cities, and each of those movement is affecting the built environment, which therefore affects our health. The other thing that it's not just buildings is there are now laws and public policy based on the things that Jon Snow found, based on the things that Florence Nightingale found, that we put limits and we put programs in place to change zoning, right? You cannot necessarily live where you work. There are land use and planning people that get together to figure out, all right, here's where businesses are going to be, here's where green space is going to be, here's where people are going to live. And for a long time, public health was missing from that table. They are starting to be invited now, but for a long time, so a lot of the older policies, the older zoning regulations, they didn't take into account public health and how the built environment might affect health. Fortunately, now we know a lot about how the built environment affects health. We know that green space is very important, not only for healthy food access and community gardens, it's important for the mental health of communities. We know that living close to where you work is not necessarily great for your mental health. But we also know that there are accessibility issues if you don't live near where you work. There are accessibility issues if you do live near where you work. And all of that has an effect on mental health. We know that there is a big difference between people living in urban environments and people living in rural environments. We know that living in one environment and working in another environment is going to require the use of some kind of transportation, whether that's a personal automobile or it's public transport. We know that cities need to be walkable or cyclable in order for people to get physical exercise, to have good mental health. So if cities are doing that, great. If cities aren't doing that, can there be public policies or procedures in place to allow for that? We know that water quality and air quality are important for good health. So what are we doing about those things? Because it's always a balancing act, right? So cities are going to have more people, they're probably going to have more pollution, which means the air quality is going to go down. People are going to have more people, cities are going to have more people that are going to need to use more water. So what is the water quality like? How is it cleaned? Where is it coming from? And we see a lot of these things when they fail. So we saw what happened when a city suddenly changes where they get their water from, and all of a sudden Flint, Michigan happens, and a whole lot of people don't have access to clean water. We see cities next to power plants, coal plants, whatever plants, and something goes wrong at one of those plants, and all of a sudden the air quality is not great. We saw the air quality from the Canadian wildfires come down into the United States. And all of a sudden everybody was dealing with poor air quality, and people were saying, put your masks back on, don't go outside. So a lot of the built environment is, within a country or within a city, but some of the built environment does not, conform to state lines or country lines. And it is something that we're going to have to deal with, figuring out what our neighbors are up to and if we can do anything about that as well. So let's talk about Delaware a little bit. Fortunately for Delaware, there are quite a few policies, procedures, programs that are focused on the built environment in some way or shape or form. And a lot of what we're doing is looking at what policies and procedures can Delaware institute, what are we instituting, what's missing from what we're instituting, and how can we add to that to, give everybody the best possible life with green spaces and blue spaces and access to fresh fruits and vegetables. So let's talk about some of those things. All right, so green spaces is anything, quote unquote green, but it's also blue. So it's any place where you don't have a building. So it can be a park, it can be a community garden, it can be a cemetery or a graveyard, it can be meadows and woods. It can also be things like rooftop gardens and vertical gardens, but also it can be blue spaces. So it can be ditches or canals or inland waterways or rivers and riverbanks. So if anybody has ever been to the Wilmington riverfront, that's considered a green blue space. There are places to walk, there's green, there's trees, there's water there. Where the buildings can be is limited. What green and blue spaces do is they decrease population density. If you can't have a building there, then the population density is going to decrease. It promotes active living because It promotes recreational activity. It increases leisure time. You can walk from point A to point B. You can go fishing. You can go for a run, whatever. It also reduces flood risk. So the more trees and plants and green things you have growing in the ground, the more water they're going to be able to suck up when it rains. If you have a deluge and we have rain for 3 days, those areas are going to suck up a lot of the water. Versus if we have blacktop or sidewalks, none of the water is going to get sucked up and it's all going to be sluiced down to someplace else. The green things living there and the water are going to cool the city. So blacktop will reflect the heat back up, and it will lead to increased global warming and greenhouse gases and all that kind of stuff. The trees are going to suck up the carbon dioxide. The trees are going to suck up the heat and provide shade. Green things increase biodiversity. They also increase consumption, not only by the biodiverse critters living there, but because green spaces include places like farmland or community gardens. So we increase consumption of healthy fruits and vegetables. As I said, we decrease greenhouse gas emissions and we decrease urban heat islands. We know that in urban areas, if we start planting trees, the temperature of those areas decreases because the trees help to mitigate the sunlight and they shade and provide shade and coolness and all that kind of stuff. So when we look at land cover, green spaces, that includes forests, wetlands, agricultural fields, and it compares those things to developed lands. So things like impervious surfaces, like highways and freeways and parking lots. Those developed areas, the impervious spaces, have a relative heating effect, meaning increases the heat, and it increases the flood potential. The trees and vegetation have a relative cooling effect, minimizes flooding, and it mitigates air pollution. So we can't have all of the spaces be covered with trees, but equally we can't have all of the spaces be covered with blacktop. We have to find that happy little medium where we have both of those things, enough that we can do the things that we need with the built environment while also mitigating our risk of flood and heating effect. These pictures are, any picture that looks like the pictures on this slide are taken from My Healthy Community, by the way. So this is what Delaware looks like. The left is the developed land. We see a lot of developed land in Wilmington and up in Newcastle County, which is kind of obvious if you think about it. But we also see tree canopy in some of those areas of developed land. So that's a good thing, right? The other thing that I want to talk about is location, right? So the built environment is where you live and work and play. So where you live and work and play has an effect on your health. So a couple of things that we're looking at. The left-hand side, the one with a lot of the blue on the map, that is the residential segregation index. So that's the degree to which two groups live separately from one another in any kind of geographic area and how well they're integrated. So this can take this takes redlining into effect. It takes structural inequalities into effect. Socioeconomic mobility. Can you move out of an area? Are there environmental hazards in that area? So a 0 is a complete integration and 100% is complete segregation. Delaware sits, their racial segregation index is at about 44%. So we're closer to integration than segregation. Newcastle County is at 46%. Kent County is at 29%. So Kent County has more integration than Newcastle or Sussex, which has 44%. So the blue area on this map is majority white. The yellow area is majority Hispanic. The green area is majority Black, and the pink area is majority Asian. The white area is an area where people don't live. And being segregated by your ethnic group or by your religious group or by your whatever group has its costs and its benefits. So we know that people's mental health is better when they're surrounded by people who look like them and think like them and have the same cultural background as them. At the same time, we know that segregating those areas does not necessarily lead to good things happening from a political standpoint or a legislative standpoint. So if those people are not elected to represent their communities, then those communities can get left behind. If there are people who are being elected and they are from those communities, then those communities get, their stories told. So there is a give and take there. We know that it's important that people live around people who look and think and feel like them, but also we want to make sure that those people are also at all of the tables that they need to be at. The map on the right, the diversity map, how many different people with different races, ethnicities live close to one another? So Wilmington is 86 out of 100. And again, there is a pro-con. The more different the people, the more different specialities, the more likely you are to find somebody who does a certain thing. The con is that maybe you're not surrounded by people who look like you and think like you. But all of these location things we need to think about. Can you get out of that area if you need to access something? Can we bring things to you? If you do not have access to something, can we bring it to you, or can you get to it? And when I'm saying access to things, I'm thinking healthcare, food, education. If people live in a city, they might not have a car. Is there mass transit to get them from outside of their neighborhood? Otherwise, they're stuck with what we can get into their neighborhood, or what their neighborhood can bring to the people within. From a transportation point of view, this is the transportation map of Delaware from DART. So there are 6 maps. I've put them all together so that you can kind of see by county. But you can see that there are a lot of mass transit options available for people living in Newcastle. The DART goes to a lot of places. In Kent and Sussex County, not so much. So if you are somebody who lives in rural Sussex County and you don't have a car, how are you going to get to Beebe? How are you going to get to the grocery store? Are you going to have to borrow somebody's car? Can you walk to the bus stop, and does the bus take you where you need to go? So these are things that we're thinking about from a transportation point of view. Again, access to transportation, and then access to everything else. How are you going to get your kids to school? How are you going to get to the doctor? How can you get to the grocery store? Which grocery store is closest? So if we're looking at things like how the built environment affects health, this is one of the ways that we can rank our counties and our states and what have you. It's called county health rankings. And what they do is they take a snapshot of every county in the United States. And based on both health outcomes and health factors, they look at the health of the county, and then they compare it to the other counties in the state. So in Delaware, Kent County is compared to Sussex County is compared to Newcastle County. But you can see that the built environment makes up a good 50% of the health factors that people have to deal with. It makes up the social and economic factors, and it makes up the physical environment. It's not how healthy somebody is, only has about 20% to do with actually getting healthcare. So some of the numbers I pulled from County Health Rankings, 2023 numbers. The Food Environment Index, so is out of 10, how much access do you have to healthy food? How food insecure is a community? So Delaware as a whole has pretty good access to healthy food, but Newcastle is doing better than Sussex, who is doing better than Kent. Physical activity, what percentage of the population does not engage in any kind of physical activity other than getting to and from work? Access to exercise, what percentage of the population has access to exercise or exercise facilities? Air pollution is the number of micrograms per meter cubed. So the average standard for air pollution is 12 micrograms per meter cubed. Newcastle County sees more air pollution than Kent or Sussex County. Drinking water violations are pretty self-explanatory. Have there been any? And then the last one, what percentage of the population has some kind of housing problem? So let's talk about that last one. What could that look like? Housing issues affecting health. Materials that we build with. Radon. We know that radon is located in the soil and the stone and can lead to lung cancer. That's why we have to do a radon check every time we sell our house. We know that asbestos leads to things like mesothelioma and lung cancer and asbestosis and throat cancer and all kinds of pleural effusions. but we know it still exists in shingles and sidings and insulation and tile. We know that if we leave those things alone, we're probably fine. But if we're going to start pulling up tile or shingles or whatever, we have to check to make sure that there's no asbestos. And if we find it, we have to deal with it. And dealing with it leads to pulling it up and putting it in plastic bags and making a hazmat sign and all that kind of stuff. We know that the urethane foam that people used in insulation can lead to cancer or neurological disorders or autoimmune disease. We know that polychlorinated biphenyls were used in sealants that can lead to melanoma cancer. We know that heavy metals can lead to neurologic disorders. We know that we used lead paint in the past. So we know that there are places in Delaware where people are living in houses with these issues. So A, we want to find those places. B, we want to clean up those places so that these people don't have to keep dealing with that. The American Public Health Association says that the serious housing problems in Delaware decreased from 16.1% to 14.3% of occupied units, which is great. But that means that there are still 14.3% of people who have these things in their house. And the important thing is they may not know about it. So are there policies and procedures in place where people can go in and have a look at lead paint? We know that there are tests for lead paint for young children because we know it's dangerous. You have to do a lead test for your children. But what else can we do to protect people? Access to healthy food. So I kind of touched on this before. We know that your zip code has a lot to do with how healthy you are, because your zip code has a lot to do with the income that you pull in, the race and ethnicity that you are, what type of house you can afford, where you're located. But the thing that I want to impress upon you here is that you might have access to a store. That store does not necessarily have healthy food. We see a lot of what's called food deserts. So 33% of the population in Delaware is more than 1 mile from a grocery store or a store that sells healthy fruit and vegetables, or are more than 10 miles from a grocery store that sells healthy fruit and vegetables if they're in a rural area. So if you can't get to, your doctor says you have heart disease, you need to eat a healthy diet. If you can't get to somewhere that sells those fruits and vegetables, how are you going to follow that prescription? If you can't afford those healthy fruits and vegetables, how are you going to afford that prescription? Because a lot of the cheaper food that's accessible to a lot of people are the highly processed, lives in a box kind of food. So if you don't have access, how are you going to get them? And that access includes transportation. If you don't live near a grocery store and you live in the city of Wilmington, if you don't have a car, you're not going to go outside of Wilmington. You're going to go to your corner store or your corner market. If that market doesn't have fruits and vegetables, then you're not going to eat the fruits and vegetables. If you can't afford the fruits and vegetables, you're not going to eat the fruit and vegetables. It is both a rural and an urban issue. So we're talking about grocery stores, but we also have farmers markets or co-ops or community gardens. Healthy food is becoming something that we're more and more aware of, and more and more aware that people don't have access to. So we are seeing a lot of farmers markets pop up in inner cities. We're seeing a lot of co-ops. We're seeing a lot of community gardens, and that's great. It's amazing. But we know that 1 in 7 children in Delaware face hunger. We know that people do not make enough money to meet their food needs. We know that 1 in 10 people face hunger, not just children. And having this issue, not having access to food, facing hunger, can lead to malnutrition, obviously, and starvation, but it also leads to obesity because you are eating the highly processed foods, because you're not eating the 5 fruits and vegetables a day. We have food insecurity in Delaware. 12.9% of our population is food insecure, and 5.1% are very low food insecure. We know that 43.7% of households receiving SNAP benefits have children. So this is an issue. You can see on this map of Delaware, the map on the left, the areas in the orange and the red are food deserts. They don't have access to a grocery store. We see the green dots are the percentage of SNAP recipients. We see a lot of those in the cities. And the map on the right are maps of community gardens throughout Delaware. So these, we're seeing that we don't necessarily have as many problems where we see those community gardens. So is the answer to make more community gardens? Is the answer to more transportation lines? I don't know. But this is things that we have to think about when we're thinking about the built environment and how it affects health. We also think about sedentary lifestyle. So I've said, now that we commute from point A to point B, we don't have to walk 2 miles to work. It leads to physical inactivity. You can see that Delaware is ranked number 40 out of 50 states on sedentary lifestyle. We have a lot of people, 27.2%, who live a sedentary lifestyle. They don't move around a lot. We know from a medical perspective that physical activity is good for you. It is recommended that people get however many minutes per week, either 150 minutes per week of moderate intensity or 75 minutes per week of vigorous intensity. It's recommended that we pick up heavy things and put them down at least 2 days a week. But only 1 in 4 adults and 1 in 6 high school students meet these recommendations. We know that physical activity reduces the risk of cardiovascular disease, of hypertension, of diabetes, of cancer, of dementia, of anxiety and depression. But we haven't built an environment where the good thing to do is the easy thing to do. We have to include in our environment, we have to integrate health considerations into building projects. It's great because right now I'm sitting at the basement of the Ammon Center in Christiana Hospital, and there are little walking paths throughout the hospital, and there's a little duck pond that I can walk around outside if I need to take a break. I have green spaces. I have walking paths or biking paths. I can walk from point A to point B. But just because I have them doesn't necessarily mean that other people can access them. I have a walking path. Can somebody in a wheelchair access that walking path? Can somebody who, can't walk as well as I can they access some kind of movement or physical activity? Are these things integrated into the environment? Do we have zoning for these things? So while I would love to say that the easiest thing to do would be to write a prescription to eat healthy foods 3 times a day and get outdoor exercise daily and eat fruits and vegetables, it's not as simple as that. There are things that need to be taken into account. One of the ways that we have started to integrate physical activity into building projects is we look at walkability and bikeability of different cities and areas. So the walkability is the accessibility of things by foot. You see this in cities. Urban spaces should be able to be used by a variety of users for a variety of different uses and modes of transportation. So I should be able to walk from point A to point B. Somebody in a wheelchair should be able to get from point A to point B without needing to get into a car or into a mass transit vehicle. It has health benefits and economic benefits and environmental benefits. Health benefits because I'm moving around. Economic benefits because I'm walking from store to store and ostensibly buying things each time I go places. And environmental because I'm cutting out the pollution that I would otherwise be putting on my car if I had to drive from point A to point B. But there are factors to think about, right? It's always a balancing act. Density, how close together are the buildings? How close together, how much population lives there? If the buildings are really, really far apart, people probably aren't going to want to walk from one building to another. If they're very close, they probably will. But if they're very close, how many other people are doing that? Can the area sustain that many people walking around? Is there a functional mix? Can people live there, work there, and visit there? Do you have access? Can you get into the city? Can I take a train into the city and then walk around the city? Are there footpaths? Are they safe? Is there a buffer to traffic? What's the traffic volume like? What if we have bad weather? What if it's dark? Is it well lit? All of these things are things that people who are trying to figure out how to make cities and places more walkable, they have to think about. Now, Wilmington has an average walk score of 74, which is good. It is somewhat bikeable with a score of 52. There are lots of hills in Wilmington. So if we think about the bikeability, that's exactly the same as the walkability, except it's the degree of ease of bicycle circulation. So again, health, economic, and environmental benefits, but things we have to think about. Safety. Are the bike paths segregated from the driving paths? What's the path width? Can people pass safely? Is it visible? What happens at intersections? What obstacles are in the way? Do people double park in the bike lanes? Is there coherence and continuity? Can you park your bike in a bike rack? Can you bike the whole way, or can you only bike part of the way? Is there a direct route? Is there a flat path? In San Francisco, they started doing like a little escalator for bikes where you can sit on your bike, you can put one foot on a ground, and it'll like push you up the hill so that you don't necessarily have to bike up the hill. So these are all things that you have to think about from a bikeability and a walkability standpoint. One of the things that is a built environment issue, but is not necessarily stuck to a state or a community, is air quality, because air quality does not recognize state boundaries, right? So this is something, World Air Quality Index, you can go on it and figure out what the air quality is at any given time, but this is one for Delaware. And from DENREC, they say that most of our point sources, so our single source points of air pollution, only make up less than 10% of the air quality, air pollution that we see. Most of our air pollution is made up, about 66% of our air pollution is made up from mobile sources, meaning cars, boats, and planes. We have 0.25% made up from natural sources like radon gas and forest emissions, but only less than 10% are due from the things that people think make up the most air pollution sources, like big office buildings and landfills and hospitals and stuff. But really, according to DENREC, less than 10% of our air pollution comes from those things. Most of it is from motor vehicles, boats, and aircraft. The health effects of air pollution are great and are many, and we see it a lot. We saw it this past summer when all of a sudden all the bushfires from Canada were coming past the border and into Maine and then Connecticut and then New York. New York turned orange, but even the air quality here wasn't that great. We saw an increase in respiratory disease and asthma and allergies in COPD. We saw an increase in cardiovascular disease. We saw an increase in hospital visits. And these health effects are both short and long term, right? So it could be short term if the temperature goes up, we see more ozone related issues. Temperature goes back down, we see fewer. We see wildfires, we see a lot of particulate matter. Once it starts to rain and tamps that particulate matter down, we'll see less issues there. We see more allergen exposure when it's dry and dusty. So the other things that we have to think about, flooding. Not only do we have to think about, green areas will decrease the flooding, black areas, blacktop areas will increase, but we need to think from a medical standpoint. The more flooding we see, the more contamination we're going to see. So we're going to have human and livestock waste where it wouldn't normally be. We're going to have household waste, medical waste, hazmat waste where it wouldn't necessarily be. We might see coal ash going places that it wouldn't necessarily be. You will also see direct patient care issues like skin rashes and wounds and GI illness, diarrhea, tetanus, animal bites, all of those things if we see lots of flooding. Delaware is on the coastline, and we will see flooding. We see flooding whenever we get any kind of major storm. So this is something to think about. Can we plant trees and plants closer to the shoreline to try and suck up some of that flooding? Would that work? It's an option. As temperatures increase, we're going to see more heat stroke. We're going to see more syncope. We're going to see more rhabdomyolysis, more dehydration. And honestly, with the way climate change is going, we're only going to see higher and higher temperatures. So that is going to have an effect on health. There are lots of other parts of the built environment that I didn't touch on because it is weird and wonderful and everything is public health. But this is just kind of like a built environment primer. And I am happy to take any questions if anybody has any.
Thank you so much, Kate. This is a little overwhelming in terms of what to do.
Yeah.
What to do? I mean, there are so many problems. Any question from the audience? Let's check the chat. Oh, Dr. Khan?
Hi, thank you so much. Kate, thank you for that wonderful presentation. As Dr. Jerkovich said, it's such a broad area, and I think I really appreciate the breadth that, in fact, you provided. I had a question about, well, more a comment around I'm struck by how much the built environment plays a role in so many other aspects of the social determinants of health. And so many of the things that we research, we must be attentive to some of those bigger pictures. Just for example, when we study access barriers to healthcare, and we study access barriers at one micro level, say in the health system, but then if we're not attentive to the built environment and broader barriers around structural determinants, violence, roads, transport, whether there's a bus route, it really doesn't matter if we build ramps at the entrance to our health system if somebody can't leave their home safely. And I wonder if in Delaware, do you feel like, to get to Dr. Jerkovitz's point as well, do you feel that we have a public health framework that allows us to look at the breadth of these issues, but then address them in the appropriate micro ways? Because that's the only way we're going to be addressing them, not to wave a wand for the bigger picture. But can you outline for us what's the framework for folks to get involved in that piece of it? And where do you see some emerging areas of perhaps research and intervention that this group could maybe go after and make more of an impact on? Thanks so much.
Yes, way to ask the easy questions, right? There is no real easy answer, because what we find in public health is if we come up with this great plan to do something, there are going to be people and places and situations it's not going to work for. And you would think Delaware would be easy because we're so small and we're like, hey, we have one public health department and this is great. And it's not the answer. We cannot come up with one thing that's going to work for everybody. Delaware is this really interesting microcosm where if we can figure it out, we could probably make it work for everybody, because we have a rural area and a suburban area and an urban area. Unfortunately, what works for one is not going to work for another. A great example of this is that recently the Delaware Academy of Medicine has been doing research into the healthcare providers in the state of Delaware. And I'm not just talking about doctors, I'm talking about nurses and OTs and PTs and SLPs and all kinds of people, vets and funeral services, and where they are. So, you know, the anecdotal evidence has always said, well, Newcastle has all of the doctors, and Kent and Sussex County don't have any. And we're finding that Newcastle has a lot of doctors, but Kent and Sussex County has a lot too. And a lot of that is helped by, you know, the new residency programs in both of those hospitals. But maybe the specialists are only located in one area, because as much as we want to have specialists in all parts of Delaware, it might not make sense from a fiscal perspective of that specialist, right? They might not see a whole lot of, I don't know, let's say they're a renal doc. They might, if they were to move down to the BB area, there might not be enough people down there to, you know, have them stay. So maybe they have to go back and forth. So a lot of things in public health are not necessarily going to work for everything. So my suggestion is we have a lot of grassroots things in Delaware. We have big major healthcare institutions who are trying to do the right thing and for all of their public, which is great. But we also need to have those boots on the ground and figuring out what exactly is needed in this community. How can we get those things here? Because I can come in and say, hey, I have money for, you know, transportation access, and the community might say to me, yeah, we don't care about transportation access. Our children are drowning in swimming pools or something like that. So having the stakeholders in the communities who are willing to stand up and be like, this is what we need, and then working with the state, working with the academy, working with the major healthcare institutions to figure out what kind of programs might work for that area is probably what's going to get it done.
Omar, you are muted.
Sorry, thank you, Claudine. Thank you, Kate. That's very helpful. And I wanted to add that for folks who are already engaged in research projects, you know, we have a research agenda across the institutions and the attendees that are here. But I think the information Dr. Smith presented is great foundational work, perhaps for your grant applications and others. And Kate, if you wouldn't mind sharing them with Deborah as well, and she can make them available, certainly the county health rankings, links and so forth. That looks like that's great background or for many of the research projects that we're all engaged in. So thank you again for that.
Yeah.
Thanks, Kate. So there are a couple of comments in the chat. Kate Shady, Kate, you want to open the conversation? Kate Shady? I know she was around here.
I can. I was just saying that I work on the cancer floor, and we definitely see a significantly increased population coming from the lower parts of the state versus the higher parts, with different cancer diagnoses, particularly leukemias.
Thank you, Kate. And Tracy, I think, is making a comment, being surprised at the statistic related to Kent County. Which statistics exactly are you referring to, Tracy?
I was just referring to the access to, I can't remember what slide it was, but the percentage was considerably lower for people trying, access to like working out and so forth. It was a slide you had earlier on, but the statistics were very, very surprising. It was a very, very good presentation.
Yeah, so I will say, remember with statistics, so especially for the county health rankings and America's health rankings, I just put the links to those in the chat if you're interested. County health rankings, I definitely recommend you click around and have a look. But keep in mind that that's all dependent on who's answering the surveys, and they're all point in time surveys. So I tried to make that apparent with the county health rankings. The county health rankings is a point in time. These people answered the survey. This is what they said. And then they'll compare, Kent to Sussex and Newcastle. It doesn't have any kind of time in it. So it doesn't compare how Kent has been doing for the past couple of years. The report is just, this is how it's doing versus Sussex and Newcastle, which is kind of helpful, but it's kind of not, because, 3 counties does not really make a great statistical group. If you go into the county health rankings, you can look at each of those factors over the course of however long they've been getting that information. And I think that is more helpful, because you can see, like, from a time perspective, are they getting better? Are they getting worse? So, I mean, statistics is a great place to start, but keep in mind that that's just the people who answer studies. There are a lot of people who don't answer phone calls and surveys.
Yeah, that's true. So I have a question related to hunger. I mean, I was really shocked to see the statistics that you showed about the hunger in children. And I mean, it seems 47%, I think. Is it what you said?
Yeah.
I mean, it's really, it's really incredible. I mean, it's so high. Are there initiatives, taken by the state and by the Department of Public Health to resolve this issue, to improve? Is hunger located to, very specific communities? Do we know that?
So the way that they look at hunger is, do you have access to healthy food? And access to food is one thing, and then access to healthy food is a completely different story. So while most people might have access to food in that they can get to a store that sells food, the food that they are getting is not necessarily great. The program that the state relies on is the Food Bank of Delaware, which is great if you can get yourself to the food bank and you can pick up the food. If you don't have transportation, how are you going to get to the food bank? There are a lot of little grassroots things going on, like church food banks and church soup kitchens. There are a lot of people working on getting community gardens up and running in the more urban areas. The city of Wilmington has a couple of them. Getting co-ops, bringing those types of healthy fruits and vegetables into where people are working. Christiana Hospital, I think it's a Thursday, will have people from farmers markets bring in produce to buy. So there are lots of little things, but again, there's no one thing that one group is doing that's kind of going throughout the state other than the food bank.
Thanks. Any other questions for Dr. Smith? Well, I guess. I mean, I have a last question. Also the walkability numbers. I mean, you said Wilmington had really a good walkability rate. I think you said 74, mentioned that. But I mean, I guess it's on average because I mean, I know that there are places in Wilmington you really cannot walk, and there are a few places where you can walk. So it's a little difficult to I don't know, to evaluate. It seems to me to evaluate the walkability. Maybe it's better to do it neighborhood by neighborhood if you want to improve the health of people, you know, in a specific neighborhood.
Yeah, and I mean, each neighborhood's going to be different as to what they need, right? So you are going to have neighborhoods in Wilmington that I do not want to be walking in as soon as the sun goes down. So maybe that answer is we put in more lights or more security guards or more
Or
police presence.
some pavements, so you just cannot walk because
Yeah,
there are no pavements, you know.
Or pavements, or you know, a distinct difference between the road and where I can walk.
Right.
It's going to be different depending on what's already been done in an area, and it's going to be different depending on the income of the area. The more the higher the socioeconomic status of a neighborhood, the more likely they're going to have a nice tree-lined street with sidewalks and you know, neighborhood watch and safety for children as they're playing in the street. The lower the socioeconomic status, the more we see cracked sidewalks and lots of cars parked and very few well-lit streets. And so it's going to depend on what each neighborhood needs to become walkable. There's no one right answer that's going to do anything. And that's the problem with public health. I have all kinds of great answers for you, and it's not going to work for everybody.
Exactly. Well, thank you so much. This was really fascinating and very, very instructive and
Thanks for having me.
wonderful discussion.